heart failure is an extremely rewarding disease to treat. And one of the reasons it's so rewarding is because we can make such huge differences to our patients. And these differences are really important because they include making huge differences and huge reductions in patients' mortality. This is a similar slide that we saw in the previous presentation, showing some of the risk reduction seen, the absolute risk reduction seen in the studies looking at heart failure interventions. On the left, in blue, drug interventions. So consensus with enalapril, an ACE inhibitor, RALS and spironolactone, and Cibis and bisoprolol. Next, in the pink, the addition of devices when we compare the treatment group with the control group. Resynchronization therapy and ICD therapy can equally result in big differences in patient mortality. But one important arm of the treatment, a complete treatment of patients with heart failure, is the involvement of a multidisciplinary team in the care of patients. And published data already demonstrate that when patients with heart failure are cared for by a multidisciplinary team, there is, again, a significant and sizable reduction, absolute risk reduction in patient mortality. I believe that the published data, shown in green on this graph, underestimates the effect that a multidisciplinary team can have, and I'll show some data a bit later to back that up. So, as previously alluded to, despite all the advances in the treatment of heart failure, with drugs, with devices, the prognosis frequently remains poor. A huge amount of money and healthcare burden is expended on patients with heart failure in the UK. We spend around $3 billion a year treating heart failure, and a lot of that cost comes with the admissions, heart failure admissions. Now, heart failure is a complex syndrome causing multi-system morbidity, psychological ill health, and social problems. And it therefore makes sense that the treatment for heart failure, best treatment for heart failure, is multifaceted to reflect the disease affecting, how the disease affects individuals. So studies looking at the involvement of multidisciplinary teams in the treatment of patients with heart failure have now enrolled more than 8,000 patients. And there have been a couple of pooled analyses looking at these studies, which have demonstrated that multidisciplinary teams looking after patients with heart failure reduce admissions, reduce heart failure and all-cause admissions, reduce mortality, and also improve patient well-being. A number of studies have also looked at cost effectiveness, and all of the studies which have evaluated cost effectiveness of multidisciplinary strategies demonstrate that this is cost effective by reducing hospital admissions. So just to look at that a little more closely, this is a systematic review of randomized trials of multidisciplinary strategies for the management of heart failure patients. In this study, these were people who had been identified as being at high risk for admission with heart failure. So strategies that incorporated follow-up by a specialist multidisciplinary team, and it didn't matter whether that was in the hospital, in a clinic, or in a non-clinic setting, had these effects on outcome. So mortality, relative risk reduction in mortality of 25%, similar sort of reduction in hospitalizations for heart failure, and also significant and sizable reduction in all-cause hospitalizations. Now, obviously, multidisciplinary care is a fairly broad term, and the most impressive results were achieved when patients had access to specialist follow-up. Strategies that employed telephone contact or who advised patients to go to their primary care physician, their GP, if they felt worse, were helpful in reducing hospitalizations, but didn't reduce mortality. And equally, programs that just looked at education and promoting self-care activities resulted in reduced hospitalization from heart failure, all-cause hospitalizations, but didn't affect mortality. So just to re-emphasize that, really, the aspects of multidisciplinary care which seemed to have most effect were follow-up by specialist staff, and that could be at home or in the hospital, and access to specialist heart failure clinics. The difficulty with putting all these studies together in a systematic review is that you might think a diverse range of interventions might qualify as multidisciplinary care. It then becomes difficult to unpick which aspects are most important and useful. But looking at the studies carefully, most trials tested pretty similar interventions and consistently follow access to specialist staff and one-to-one education with the patient were the aspects which seemed to provide the biggest benefit, and those were the studies which were able to show a reduction in mortality. So education tended to be given over a number of encounters with the patient, and again, it didn't really matter where that education was delivered or by who. Perhaps equally importantly, what comes out of this work is what an MDT doesn't have to be. So if you compare high-intensity interventions to low-intensity interventions, high-intensity interventions seem to be better, but the difference was pretty marginal and the confidence intervals overlap. So it doesn't have to be very high-intensity, very labor-intensive. Some studies have specifically targeted high-risk patients. However, targeting all patients equally has been shown to be effective. It's not just something to target at high-risk patients. You'll frequently hear people say that we don't have any treatment for heart failure with a preserved ejection fraction that's been shown to reduce mortality. But many of the patients entered in these studies did have preserved ejection fraction, and they are a group of patients who also appear to benefit from this multidisciplinary approach. It's also interesting to note that the trial results didn't appear to change over time, that the magnitude of the benefit from involving a multidisciplinary team didn't appear to change over time, despite increased use of ACE inhibitors and beta blockers as time went on, as the studies became more contemporary. And this suggests that the effectiveness of the MDT is probably not just mediated by patients taking their tablet, being told to and being supervised and being helped and facilitated in taking their tablets. It's probably, there's probably more to the effect than that, and I certainly believe that's likely to be the case. So you might ask what constitutes an MDT, and again, that's something that is a little bit variable. In my opinion, there are some team members who it's compulsory to have in the MDT, whereas others, you may chop and change them and vary them according to who's available locally and your local setup and networks. So the heart failure team has to be led by a specialist, which in the UK, and I suspect in most places, almost always a cardiologist. There are some models around where heart failure teams are led by physicians with an interest in heart failure who are not necessarily cardiologists. A key component of the multidisciplinary team is are the heart failure specialist nurses who deliver a lot of that patient education and ongoing management outlined previously. And heart failure specialist nurses can work both within the hospital setup and in the community. Finally, the last key aspect is really some admin support, because unless you want your clinical staff to spend the whole time booking appointments, filling out notes and so forth, then I think it's really key to have some admin support. Beyond that, there are often other members of the heart failure team who are valuable and bring extra value, and they may include trainees, pharmacists, their models who've used physiotherapists, psychologists, palliative care, dietitians, social workers, the list goes on. And really, I think different models are likely to be effective in different settings. So how's this all been translated into guidelines? Well, the ESC have given a Class 1A indication to involving a multidisciplinary team in the care of patients with heart failure, although they state that it is to reduce readmissions, not mortality, because some of the studies only, or some of the strategies only showed a reduction in readmissions, as I mentioned. The ACC, the American guidelines, give a Class 1B indication for the involvement of a multidisciplinary team, and they talk about targeting patients at high risk, because potentially those are the ones who benefit the most. And in the UK, we have our NICE guidelines, as previously alluded to, and both chronic and acute heart failure guidelines in the UK advocate the involvement of a multidisciplinary team. So, although specialist multidisciplinary teams have been shown to improve outcome, as I've outlined, the vast majority of published data actually relate to interventions that start at discharge and that take place in outpatients. However, given the high inpatient mortality and early post-discharge mortality and readmissions, I really think that involving the multidisciplinary team in the care of patients earlier in their pathway when they're admitted with heart failure and during their inpatient stay is likely to provide some extra benefit. And perhaps surprisingly, there's very little published data on using MDTs for inpatients. So these are some data from the UK National Heart Failure Audit, which is the same data that the same audit that Dr. Calra showed earlier. So as a reminder, more than 40,000 patients admitted in the UK with heart failure were entered into this last audit. And one thing that is consistently shown is that if you're a patient admitted with heart failure, if you come under the care of cardiology, then your mortality as an inpatient is significantly lower than your mortality if you're admitted under non-specialist team. And that's even after adjustment for co-founders. So this graph goes on beyond the initial admission. The top line in green is for patients admitted under cardiology, and then that benefit is maintained over a number of years of follow-up. And I suspect some of this benefit relates to the involvement of the MDT in patients who are admitted to cardiology. These data I'm going to show are as yet unpublished, but hopefully will be in the not too distant future, looking at what impact an inpatient multidisciplinary team may make to patients with heart failure. So locally, we looked at 200 patients before and after the introduction of a multidisciplinary team to look at inpatients with heart failure. So patients who are admitted with heart failure, we set up a multidisciplinary team consisting of the members outlined earlier, and really central to that was involving heart failure specialist nurses. And we compared 200 patients the first 200 patients seen by that team with the 200 patients seen and managed prior to the introduction of this team. When we looked at the baseline characteristics, what this table shows is there was really very little difference. So there were no important differences between the cohort of patients that were being managed by the heart failure team and those who were not being managed by the heart failure team. A significant number had systolic impairment and the sort of comorbidities you'd probably expect to see in a UK patient population admitted with heart failure. So these are the results. In the blue columns are the results from the patients before we introduced the heart failure team, pre-heart failure team, and the red columns after the introduction of the heart failure team. So what we showed was that there was a big reduction in inpatient mortality, a 16% reduction, absolute risk reduction in mortality for inpatients, which was sustained, the second graph along, at a year's follow-up. We didn't have much effect on all-cause readmissions or on heart failure admissions. They were not significantly different. But what we did do is a lot more patients were followed up by the specialist team when they, after the introduction of the inpatient heart failure team. Partly, we were able to show that we were more likely to discharge patients on evidence-based drugs such as ACE inhibitors and MRAs. The differences in prescription rates were actually fairly small because very high percentages of patients were getting onto those drugs anyway. There was no difference in the rate of beta blocker prescription before and after the introduction of the heart failure team. So these are impressive data, and I've plotted them alongside the original graph that I showed, showing risk reduction, absolute risk reduction in mortality with the various interventions that we have in heart failure. I think it's a little bit cheeky probably to put our study up along these landmark randomized controlled trials. However, what it does do is it shows that I think there's almost certainly an enhanced role for multidisciplinary team involvement in patients who are admitted with heart failure, and it's likely the published data underestimate the sort of effect we can have. So we have a well-established setup locally in Portsmouth in terms of multidisciplinary care. I can't really take any credit for that. I had a very enlightened heart failure colleague working there for a number of years before I arrived, who's really set up a very comprehensive multidisciplinary program. And just to outline the sort of things that the team, particularly the heart failure nurse specialists, will do and where they do it. So this will include seeing patients for clinical review, looking through their medications, explaining why they're taking them, why it's important not to stop taking them, and discussing side effects, possible and ways and strategies for dealing with those if they arise. Our nurses can also perform bedside investigations like blood tests and ECGs, ongoing education really, because when a patient comes face to face with a clinician, they get told they have heart failure, there's an awful lot of information to exchange. They really get hit by a barrage of information, and it's very important for them to have opportunities to have that information reinforced and for questions they come up with in the meantime to be addressed. And very importantly, the heart failure nursing specialists see these patients and do a lot of the liaison work. However, the heart failure nurse specialists all have direct access to heart failure specialist consultants for advice, for ongoing clinical review as required. We run the setup within the hospital for inpatients, patients who are admitted with heart failure, but also patients who are well known to the service who come into hospital with some other problem. So if a patient with heart failure is stable, it's very common, of course, to see them decompensate when they're admitted with some other serious medical problem. And if they let our nurses know they're admitted and we see them, I think we can certainly do a lot in terms of preventing that decompensation. Patients will also get seen in their own homes, so the heart failure nurse specialist will visit them at home, which the patients like, and also provides valuable further insight into why patients behave like they do. When you understand someone's home setup, you're much more likely to understand why they don't take their drugs if that's a problem, and address issues like that. We also tend to see the heart failure nurse specialist will see patients admitted to heart failure very soon after discharge, so within 2 weeks or even earlier in selected patients as a strategy towards targeting those at very high risk of coming back or of developing problems early post-discharge. So this is a picture of our MDT in action. We have one a week. We have outpatient heart failure nurses. They always bring coffee. It's not compulsory. I don't think that was an aspect that we needed to do. We have some inpatient heart failure nurses, and we all get together. In this multidisciplinary team meeting, we also have a palliative care consultant so we can directly discuss patients nearing end of life or who involvement of palliative care may be helpful from a symptomatic point of view, and they come along once a month to facilitate direct discussion. There are a number of other team members not shown there, including admin staff, ward nurses and so forth. But what this does allow is it allows us to have a seamless transition really from patients who are seen in the outpatients, seen on the wards, as they go home back into the community. We can have direct communication about taking patients' management forward, what the plan is in terms of drug up-titration, device therapy in the future, and discuss problems as they arise. This MDT is led by a heart failure physician. You can see Dr. Wasanthi being the boss in this example. So just to summarize, multidisciplinary care in the management of patients with heart failure is extremely important. It makes patients feel better, it reduces hospitalizations, and it reduces mortality. Multidisciplinary care tends to be very variable in different settings, and the key aspects which seem to matter are access to specialist follow-up and education. I think, and I've shown you some data to support that early involvement with the heart failure team is likely to be beneficial, and it is a key part of comprehensive heart failure management programs. Whilst it's very easy to get focused on new drug treatments, fancy new devices, fancy new monitoring equipment, which is all very interesting and fascinating, it's really important not to forget the multidisciplinary team and the effect it can have in providing the best management for our patients with heart failure. Thank you.